Hi, I'm John Iredale, Pro Vice-Chancellor for Health and Life Sciences here at the University of Bristol. Welcome to the next in our series of Fireside Chats, where I'm discussing the way in which the University of Bristol is addressing the real challenges that have been posed by the COVID pandemic with academics from our university who are leading the charge of finding solutions to these intractable sometimes problems. From the early days of the COVID pandemic, it became increasingly clear that there were inequalities at play in the risks posed by the virus. It was very apparent that those who were older and those with pre-existing health conditions were at increased risk of death and of severe disease. But very rapidly it became obvious that those from Black and minority ethnic groups were at particular risk. We had a big report that was pulled together by Public Health England and disappointed many by quantifying the risk, but without actually developing some clear and discrete and applicable solutions. And recently, in fact, this week, we've heard that a study of data from 39,000 admissions to intensive care units has once again identified that although patients are equally sick when they arrive on the intensive care units, those that have serious disease come to harm and even death, those particularly of South Indian origin, are at higher risk. So how can we understand these drivers? How can we use data that we can develop or research to address these inequalities and these challenges and to design solutions? I'm joined today to discuss this by Dr. Catherine Dodds, who's a senior lecturer in public policy in Bristol's School of Public Policy, and Dr. Saffron Karlsen, senior lecturer in social research in the School of Sociology, Politics and International Studies. We'd hope to be joined by Dr. Lubaba Mamluk. Unfortunately, she can't join us today, but I know that both Catherine and Saffron are keen to tell you about some of her really important research work that she's been doing with Bristol City Council. So welcome to you both.
Thank you.
So, Saffron, I guess a useful starting point, or perhaps the best starting point, might be to ask you to describe some of the work you're doing. I know you're working with charities to look at the specific local health inequalities, but it would also be useful if you were able, if you could just tell us a bit about what Lubaba's been doing with her colleagues as well. Would that be okay?
Yeah, of course. Thank you very much, John. So an awareness that there may be a sort of ethnic patterning or ethnic inequalities in the experiences of the coronavirus pandemic is first came to light sort of in the early part of this year. So first we saw some evidence coming from the States that showed big differences between the experiences of people with different ethnicities there. And then that was further replicated in the data that we had emerging from the UK, which started with evidence around the particular ethnic patterning of deaths among NHS staff, but that was quickly sort of reinforced by data based on the wider population. And some of this, so this started off these conversations about what might be driving that. At the time, we didn't have too much empirical evidence in terms of the specific drivers of these ethnic inequalities in terms of coronavirus. But over time, we've had more of that evidence emerging from the ONS and also from the Institute of Fiscal Studies. Mm-hmm. But it's important to say that for those of us who have been working in this field for some time, this patterning of these ethnic differences wasn't particularly surprising, because it very much mirrors those of other health conditions and appears to be driven by those by very much the same sort of factors. So one of the things that's been really important in terms of understanding what's happening around ethnic inequalities in the coronavirus is to try and establish the ways in which these different factors are relating to this pandemic. And so this is why we thought it's really important to talk about the work that Lubaba Mamluk and Tim Jones, who are based in the medical school, have been doing, because they were commissioned by Bristol City Council to do a summary of the sort of existing evidence regarding what is underpinning these ethnic inequalities. So this is work that's been that's a very focal part of the really important work the Bristol City Council are doing in response to the pandemic. And it's also, it was mentioned in Parliament yesterday, so it's something that's having a really important impact and influence beyond the city as well. And the important part of this research was that while drawing attention to the whole range of different factors that go into this sort of ethnic inequalities and risk of coronavirus, what they were able to point to was the fact that while much of the discussion around the drivers of these inequalities focuses on comorbidities, as we saw in the Lancet paper yesterday, and this sort of suggestion that there might be biological or genetic differences which underpin these, what their research has shown, and again, as I say, it really replicates and draws parallels with work looking at ethnic inequalities and other health conditions, is that actually biological, genetic factors play a very small part in the generation of these inequalities. And actually what's far more important are economic factors like financial hardship, deprivation, issues with housing, and issues with employment. So these are inequalities which are driven by societal problems far more than individual or cultural ones.
That's a terrific summary, and sort of wearing my physician's hat, I guess I'm kind of grateful to you for pointing out that these health inequalities are not somehow unique to COVID, and that whilst COVID's shone a light into this rather dark corner, actually, you know, we see it in chronic disease across the UK, you know, across the developed actually, as well as in other places, the developing world, and it's something which societally we have got to deal with. You know, not just an issue for COVID that will somehow be resolved. That's really helpful. Thank you, Saffron. So taking these the data that Lubaba and you and others have pulled together, how do we identify what's important, and how do we target specific aspects of policy? I don't mean operationally. I mean how do we identify where we go to make the first interventions, and indeed, where do you think the first interventions should be? I'd be interested to hear what you both think about that. Catherine?
Thanks, John. I mean, that is the question confronting us all, and I think one of the really key issues that's emerging, if we look at the UK context in particular, is a considerable tension that's emerged throughout and is continuing and building between the UK government approach, devolved government approaches as well within the nations in the UK, but also this sense of national response versus local response. So I've been a part of and listened in on a number of health committee meetings within local governments and local authorities, where commissioners and public health leads and members of councils are sitting down and having sort of public meetings to determine local response. And what they've been crying out for from the beginning, but it's getting louder and louder, and I'm hearing it very resoundingly through the Association of the Directors of Public Health, is that at local level, those with the expertise do not have access to the data that's being collated, presumably at national level, in order to understand how to mount that local response. Public health has always been local. It's got to be contextual. So cities know their own communities. Local authorities have close working connections with, you know, sort of the Black-led organizations and the Asian-led organizations in their areas. And public health leads and the directors of public health have fostered those relationships. They've built up contact tracing networks for other communicable diseases that work very, very well. And yet the frustration in those expertise areas is that they're cut off. They've been cut off from the planning and the strategy. They don't have access to the data that they need now that the national government has sort of displaced its attempt to centralize everything and has said, oh, this is going to be a local issue now. So to me, I think that the current policy focus is very much on enabling and supporting our local directors of public health to be able to get their work that they've been attempting to try to do up and running. You mentioned at the outset, John, what was certainly widely received as a disappointing first report from Public Health England in relation to disparities. It had been originally messaged, I guess, to the media as a report that was going to be about ethnic disparity.
Yeah.
Then it grew to be about all kinds of disparities in relation to COVID. Subsequently, a second report has been released by PHE. I'm trying to remember the exact date, maybe.
No, you're right. It was 2 weeks ago. Yeah.
Very little attention, very little media attention to that. It was aiming to focus on the 4,000 plus stakeholder engagements that have been going on through March and April in response, or April and May, in response to questions around what was driving the disparities in relation to ethnicity and COVID. And that report does set up 6 key policy recommendations. I think that they're all good, but I do think that they're also tremendously bounded to really considering that I guess that frame of what public health infrastructure needs in order to mobilize, which I absolutely agree is important, including that need for local data that is live data. But I don't feel that second response from PHE and the recommendations that it makes sufficiently attends to all the issues that Saffron was just discussing about what we know about the social determinants of health. And that relates to the social determinants of chronic health, acute health disease transmission, people's capacity to act in relation to information that they receive, and even people's awareness of information. There seems to be very little sort of work or knowledge that's been undertaken, at least in the national messaging so far, about what kind of messages for behaviour change are appropriate when you tell people to stand in their gardens and interact with one another, when that's going to be just completely inappropriate for whole rafts of communities who don't live in places that have gardens.
Yeah, no, and that was a point that Emma Williamson and others have made in previous podcasts that we've had. Indeed. About domestic violence and abuse and that kind of thing. Absolutely. And I mean, another example is setting up a testing station at the airport. Yeah, it's really accessible if you don't have transport and you're living, in the outer component of the inner city, for instance.
I mean, myself and a co-author at King's got a BMJ editorial published in.
Yeah, indeed. I'm sorry, I should have cited that at the beginning.
That's okay. Yeah. That's okay. In the print edition, which we're both really pleased about, that specialises, that has really focused on race and COVID, and that was the point we were raising, very early on as we were writing it, in terms of how do we expect people to access testing. And what is that presuming about the resources to which they have access? And also, what are we expecting people to understand in terms of privacy? There are many reasons why members of our racialized communities will not be entirely trusting of handing over DNA when they're not really clear where it's going, who has access to it, what companies are involved in the testing processes, and how that data is being stored in the future.
Yeah, I think one of the things that we're also involved with at the moment, so I have some Uncover funding, and so we're using that to support the council and other local organisations in terms of answering some of these questions. So obviously we have the sort of the national level data, and I know that Bristol City Council has already commissioned Arc West and Lee Weber and others of her colleagues to have a look at how we can sort of how we can use this national data to make sort of local level decisions. But what we're doing is specifically talking to members of different ethnic minority groups, people with different ethnicities within Bristol and the Southwest, to talk about their experiences of the pandemic, to try and develop a sort of a more localized sense of the sorts of initiatives that need to happen, both in terms of supporting people currently in the immediate sort of post-pandemic period, but also in terms of thinking about how we take this forward in case this should ever happen again, but also in terms of sort of building a more accessible and inclusive society. But I also wanted to say that coming back again to something that I mentioned at the beginning, a lot of the problems with this lack of data is to do with the problematic ways in which this evidence has been engaged with from the very beginning. So one of the ways part of the frustration with this new decision about having yet another commission for race equality is that actually we don't need another inquiry in order to understand what needs to be done to resolve these problems. You know, the second PHE report, the 4,000 stakeholders expressed very clearly and explicitly the impact of institutional racism and structural racism as underpinning some of these conditions. And you know, there is a huge body of research now looking at the importance of social determinants of health in general, but also in the specific ways in which structural racism leads to these sorts of social determinants and therefore manifest in these ethnic inequalities in health. So last week I published with some colleagues from Manchester in the National Centre for Social Research some work looking at the persistence of ethnic inequalities in economic outcomes, really persisting since the 1970s and in some cases getting worse. So this is not a problem that we can put down to language problems or cultural issues or people just not understanding how the system works. You know, this is about sort of systemic problems in the ways in which people gain access and are given opportunities that other people sort of gain quite readily, and the ways in which those are problematic in and of themselves, but also lead to these sorts of health inequalities. There was an ONS report, again published yesterday, that shows the increasing income inequalities between different ethnic groups. So it's about understanding the ways in which those inequalities produce inequalities in health outcomes. So we hear all sorts about the problems of overcrowding. Again, there's this assumption that people live in overcrowding conditions, or people with certain ethnic minority backgrounds live in overcrowded conditions because they want to, because multi-generational households is an important part of their cultural expression. Actually, it's not a cultural problem, it's an economic problem. People can't afford to live in the sorts of houses that will enable them to live sort of without sharing roofs, and other sorts of things. So again, it's recognizing that this is a structural problem, recognizing that we as a society have a responsibility to respond to these conditions, rather than just assuming that the explanation for these problems is contained within these communities themselves, either by nature of their biology or because of their cultures. And once we recognize that, we start drawing in, it becomes much more than a health problem. It's an economic problem. It's about the ways in which our society is structured in so many different ways. And this is why the conversations around the Black Lives Movement is so relevant to this, because it isn't just about health, it's about everything.
Yeah, you've made the point very eloquently about the really essential, the sort of vital, use the term, challenges that rightly we're being posed, and you've just posed societally, if we're to have a more inclusive and in the context of what we're talking about, healthy society. I mean, I think that you know, you've made that point, both of you, brilliantly. And I think you know, there is a huge amount of work to be done, and it's gratifying that universities like Bristol have excellent social scientists like yourselves driving to find the key answers, so that when we make change, we can make it most effectively, most quickly, because that's what we need to do. I have to say that when these were set up, there was an implicit assumption that they were for the duration when we were all in prison during lockdown with COVID. It struck me halfway through this interview that actually it would be wonderful to come back to you both in 6 months, 9 months time, because I would be fascinated to hear about your work. Well, both of you, but so I'm just thinking about Saffron's work, working with the local ethnic groups to determine their experience of lockdown. And you're absolutely right, Saffron, saying, you know, well, we might have, there may be another threat like this, because I mean, the other thing that might be on the horizon is a second wave, and wouldn't it be great if we could manage the second wave rather better than we'd managed the first? But I'm afraid that's probably where we have to leave it. It's been fascinating and sobering, and I'm really grateful to you both. And you know, the best of luck with all your endeavours.
Thanks. We look forward to speaking to you again.